Hello everyone, this is Ahmed Nagar. Today I'm gonna talk about infective endocarditis. But first, grab your coffee, relax, and enjoy the topic. And first, I will start with the definition. Infective endocarditis is an infection involving the endocardium surface of the heart, secondary to microbial infection, which is mainly bacteria. To get a better understanding about infective endocarditis, we need to know the nature of the endocardium, as it is the innermost layer of tissue that lines the heart chambers, which is primarily made up of endothelial cells, and it should be very smooth. Any damaged area of the endocardium secondary to one of the risk factors could be affected by endocarditis. So platelet and fiber will adhere to this exposed area as it is not smooth anymore, which causes a small attached thrombus. This small attached thrombus will represent a roadside rest stop for any swimming microbe in the bloodstream. Infective endocarditis classification. Formally, we used to divide infective endocarditis into acute, subacute, and chronic, based on the duration of the signs and symptoms. But currently, we classified infective endocarditis as native valve endocarditis, which is the most common and represents 78% of the cases, and prosthetic valve infective endocarditis. And now let's talk about the microbial causes of infective endocarditis. First, Staphylococcus aureus, which is the most common, and it's very common with IV drug abusers. However, it's not the exclusive reason. Second, very dense streptococci, which can be found as normal flora of the mouse. Third, Staphylococcus epidermidis, which is happen secondary to prosthetic valve and intravenous catheter. Streptococcus puvus and Enterococcus faecalis. And with this particular kind of bacteria, we need to think about colorectal disease, like colorectal cancer or ulcerative colitis. Then Coxiella pernatae, that can be caused by exposure to infected animal. Then Hayseck group of bacteria. These organisms are tricky as they are culture negative. The name of this group is mnemonic for the group members. Finally, the fungal endocarditis, which is common among the ITU patients. Now let's talk about the risk factors for infective endocarditis. Prior history of infective endocarditis. Presence of artificial prosthetic heart valve. Certain types of congenital heart disease. Post-heart transplant or open heart surgery. Presence of cardiac implanted electronic device or intravascular catheter. Acquired degenerative valve disease. Mitral valve prolapse with valvular regurgitation. Hypertrophic cardiomyopathy and intravenous drug use. Now let's see how the patient presents with infective endocarditis. Fever, which is the most common symptom. New heart murmur or worsening of previously exist murmur. However, in case of worsening of previously exist murmur, it's very hard to be distinguished. And like any other infection, night sweats, malaise, fatigue, anorexia, weight loss, myalgia, and weakness, arthralgia, headache, and shortness of breath, Janeway lesions and cutaneous infarcts, which can be happen secondary to acute embolization of fragments from infective endocarditis vegetation. Those fragments can cause rose spots in the retina as well. Ocellular nodes, which as painful nodules happen as a result of emboli traveled from the vegetations, so the immunity system surrounds this emboli and makes a tender nodule around it. Infective endocarditis can be present by more severe presentation, which usually need level 2 or 3 care, like sepsis of unknown origin, septal pulmonary embolism, stroke or brain abscess, meningeal signs, and AKI. To diagnose infective endocarditis, we need to do some investigations. Then we can use modified Duke's criteria. So first we need to collect 3 sets of blood culture, which should be taken from peripheral sites prior to commencing antibiotics. Full blood count, serum chemistry panel with glucose. urinalysis, ECG, and echocardiogram. Modified Duke criteria, which are classified to major criteria and minor criteria. Let's start with the major criteria. And first thing is positive blood culture for infective endocarditis. Typical microorganism for infective endocarditis from two separate blood cultures or persistently positive blood cultures. Second thing is related to echocardiogram that can reveal evidence of intracardial involvement like oscillating intracardiac mass or vegetation on valve, abscess like subaortic abscess, and new partial dehiscence of prosthetic valve or new valvular regurgitation. Now let's talk about the minor criteria. Predisposing heart condition or intravenous drug use. Fever over 38 degrees Celsius. Vascular phenomena such as major arterial emboli, septic pulmonary infarcts, mycotic aneurysm, intracranial hemorrhage, conjunctival hemorrhage, and Janeway lesions. Positive blood cultures which are not meeting major criteria. Echo findings which are consistent with infective endocarditis but not meeting the major criteria. Last minor criteria is immunological phenomena such as glomerulonephritis, ocellular nudes, Roth nudes, and rheumatoid factor. Diagnosis of infective endocarditis is definite in the presence of two major criteria or one major criteria plus three minor criteria or five minor criteria. Nevertheless, one major criteria plus one minor criteria or three minor criteria will raise the possibility for infective endocarditis. So, how to manage infective endocarditis? First thing to be done is taking care of the ABC for the patient. Then we will collect the blood culture. After that, we need to check. If the patient is stable, we will wait blood culture results before starting antimicrobial. But if the patient is not stable enough to wait the blood culture results, then we will see. If the patient has native valve endocarditis, we will give amoxicillin plus or minus gentamicin with indolent presentation. On the other hand, we will give vancomycin and gentamicin with severe sepsis. But with prosthetic valve endocarditis, the empirical antibiotics which will be given are vancomycin, gentamicin, and rifampicin. After receiving the blood culture results, we will give specific antibiotic according to the detected microbe. In case of Staphylococcus endocarditis, for native valve endocarditis patient, we will give flucloxacillin if there is no history of penicillin allergy. But if there is history of penicillin allergy, we will give vancomycin and rifampicin. For prosthetic valve endocarditis patient, flucloxacillin plus rifampicin plus gentamicin will be given if no penicillin allergy mentioned in the history. And vancomycin plus rifampicin plus gentamicin will be given if there is penicillin allergy. To treat Streptococcus endocarditis, benzyl penicillin plus gentamicin will be given if there is no penicillin allergy, and vancomycin plus gentamicin will be given if there is penicillin allergy. But in case, if there is high risk for nephrotoxicity, we will give ticaplanin plus gentamicin. Last regimen will be discussed at the regimen for enterococcal endocarditis. We will give amoxicillin if there is no penicillin allergy, and vancomycin plus gentamicin for penicillin allergy patients. Keep in mind, if there is high risk of nephrotoxicity, ticaplanin plus gentamicin will be given. Finally, I would like to say, in some cases, surgical intervention is unavoidable. I hope you enjoyed the topic. See you next week with another interesting topic.